Hello and welcome to Insight Ophthalmology. This is Dr. Amrit welcoming you to a lecture on cornea. Today we are studying the clinical features of certain common bacterial keratitis. In this video, we shall be studying very specific characteristics of certain bacteria which are causing the corneal ulcer, so that we can diagnose these conditions very easily just by looking at the cornea. However, the gold standard diagnostic is corneal scraping and microbiology. So without any delay, let's get started. First, we shall be starting with the gram-positive organisms, and the most common organism which can cause corneal ulcer is the staphylococcus aureus. Now, the staphylococcus aureus is basically affecting the compromised cornea. So the cornea could be compromised either by the bullous keratopathy, or it could be a person who has viral keratitis for a long time, and that viral keratitis cornea might get secondarily infected with staphylococcus aureus, or it could be that the patient has dry eyes, or it could be that he has some ocular surface disorder. So the compromised corneas are frequently affected by staphylococcus aureus. Now, one more important thing is that it will present acutely and with marked amount of suppuration. That is, more amount of infiltration will be there, more amount of acute symptoms will be there in staphylococcus aureus. And one more important point is that staphylococcus aureus will actually form deep stromal abscesses. Now, one more staphylococcus is Staphylococcus epidermidis, which is normally a commensal in the eye. So it is a commensal in the conjunctiva where it does not cause any problem. However, from the conjunctiva, it can go and infect the cornea and it can cause keratitis. Now, unlike the Staphylococcus aureus, which causes the marked amount of suppuration, Staphylococcus epidermidis usually has an indolent course. Okay, so it causes chronic bacterial ulcer, very slow course. However, that can also progress to the stromal abscess. However, it will not be as severe as Staphylococcus aureus. So let us have a look at certain clinical pictures. This is the first picture you can see here. The patient is having a deep corneal infiltrate, round in shape with surrounding corneal edema. You can see the cornea is not very clear. And you can see CCC, that is the circumcorneal congestion. Lid edema is present. So this is the case of Staphylococcus aureus. Similarly, just have a look over here, round circular paracentral infiltrate. And this is also a very specific feature of Staph aureus, that it forms well localized infiltrate and well circumscribed and stromal abscesses. Similarly, over here, just have a look at this infiltrate. It is round, circular with surrounding corneal edema. However, this picture, this patient actually had blepharitis. That means the infection of the lids. So probably the lids were infected first, and from that the cornea got infected. You can see over here this is a peripheral ulcer, and along with that surrounding you can see certain smaller infiltrates. So this is very specific for the Staphylococcus aureus associated keratitis. Now, Staphylococcus aureus, when it is streaked in a C pattern on a blood agar. So basically, whenever we are taking scrapings from the cornea, we are going to streak it on the blood agar like this in a C-shaped manner. So the initial streaks will have more number of the bacteria, and therefore the colonies will also be more in the initial streaks compared to the later streaks. So this feature is very important in order to differentiate the growth from the infection rather than from the contamination of the plate. So whenever we see a growth like this, that means the initial streaks have more number of colonies compared to the later streaks. It indicates that it is actually a real infection and not the contamination. So the colonies that we see of Staph aureus are pearly white colonies on blood agar. Now, let us talk about the second type of gram-positive organism, and the second organism is the streptococcus. So streptococcus are actually gram-positive cocci. What I mean to say by gram-positive is that whenever we do a corneal scraping and subject it to a gram stain, the gram-positive organism will actually look bluish in color. Okay, they will look bluish in color, and the gram negative will look pinkish in color. So to be more specific, it is bluish or violet in color, and gram negative will look pinkish in color. So streptococcus are gram-positive and they are cocci. Cocci means they are spherical in shape. So they are going to look as if they are arranged in chains like this, okay, a long chain, and therefore they are called streptococcus. But sometimes they can also be arranged singly, or sometimes they can be arranged in clusters like this, okay, and sometimes they can be arranged in a pair, which is called diplococcus. So this picture over here shows a gram stain in which we can see the cocci are arranged in pairs, which means diplococcus, and this is a feature of the species Streptococcus pneumoniae. Okay, the most common species which will cause keratitis, that is corneal ulcer, in Streptococcus is Streptococcus pneumoniae, which is also called the pneumococcus. These pneumococcus are actually lancet-shaped diplococci, which are arranged with the flattened ends together. So what I mean to say is that one will be like this and the other will be like this. So their flattened ends are actually in contact with each other, and because they are present in pairs, they are called diplococcus. Now the Streptococcus species, they have a very important property that they can hemolyze the red blood cells which are present in the blood agar. Now Streptococcus viridans and Streptococcus pneumoniae, these two organisms, they can cause hemolysis of the blood agar in which they are present partially, and that is called alpha hemolysis. And Streptococcus pyogenes, however, will completely cause hemolysis of the blood cells in the blood agar, which is called beta hemolysis. So beta hemolysis is a complete hemolysis and alpha hemolysis is a partial hemolysis. Now let us talk about Streptococcus pneumoniae, because this is a very important organism causing the corneal ulcer. The ulcer that Streptococcus pneumoniae causes has a specific name, and that name is ulcer serpens. Okay, serpens reminds you of snakes. So this ulcer is called serpens because of the serpiginous or creeping spread. So what I mean by serpiginous or creeping spread is that it spreads in such a fashion from the periphery to the center. So if we have an infiltrate like this, one edge of the infiltrate will always be active. So you will have more infiltration, more corneal edema towards one edge, and the edge where we have more corneal edema is called the active edge, whereas the other edge will actually be healing. So here this part of cornea will not have that much amount of corneal edema and congestion. So such an ulcer in which there is one end which is having a progressive edge and the other edge is healing, and usually this infiltrate will be deep oval or central stromal ulceration. Such an ulcer which is spreading from periphery to center is called ulcer serpens, which is caused by Streptococcus pneumoniae. Now, there's another name apart from the ulcer serpens given to the corneal ulcer which is caused by Streptococcus pneumoniae, and the other name is hypopyon ulcer. The reason it is called hypopyon ulcer is that hypopyon is very common in Streptococcus pneumoniae. So what I mean to say by hypopyon is that hypopyon is nothing but whenever there is a corneal ulcer, there will be severe inflammation that would be triggered, and because of the inflammation, all the inflammatory cells are going to come and settle down at the bottom of the anterior chamber, and they will look whitish in color, and that whitish collection of the inflammatory cell at the bottom of the anterior chamber is called hypopyon, and this hypopyon is almost always present in a case of Streptococcus pneumoniae, and therefore it is called hypopyon corneal ulcer. Let us have a look at certain pictures of Streptococcus pneumoniae ulcer. Now have a look at this central ulcers. You can see that this is the ulcer. If you do a fluorescent staining, you would be able to tell that where the epithelial defect is present, that would be stained green. Okay, now here you can see this is actually the epithelial defect, and here you can see the whitish infiltrate area. So what it means to say, this is the advancing edge or the progressing edge, and over here is the healing edge. Also, if you would notice here, there is a small hypopyon also which is present. So this is a case of Streptococcus pneumoniae ulcer with an active and leading edge, and the other edge is the healing edge. Similarly, over here you have a look, this is the ulcer, and just look here, here it is active and here it is healing, and you can see a hypopyon also. So this is a Streptococcus pneumoniae ulcer. Now Streptococcus pneumoniae will actually look they are gram-positive cocci arranged in pairs, and therefore they are called diplococcus. And on the blood agar, you can see these greenish colonies because of the partial hemolysis, and that is called alpha hemolysis seen in streptococcus pneumonia. Now let us talk about another indolent streptococcus, just like the staphylococcus. We have streptococcus viridans. Now, important thing about streptococcus viridans is that it usually does not happen. It will happen only if the patient is taking some long-term topical steroid therapy, or he has undergone certain surgery after which he was taking some steroid therapy, right? So normally it will not affect the normal cornea. Okay, so if the patient has undergone previous penetrating keratoplasty, incisional keratomy, epikeratophobia, or the patient is using contact lens for a long time, chemical burns patients who use topical anesthetic for a long time, those people are more prone to getting streptococcus viridans. And the type of ulcer which we get in streptococcus viridans is called crystalline keratopathy, right? So it's a name given to the specific keratitis caused by streptococcus viridans, and it is called crystalline keratopathy. The reason it is called crystalline is because we will have grayish white branching stromal opacities in the cornea with very little stromal inflammation. So have a look at this picture. You can make out that this patient actually underwent penetrating keratoplasty by this graft host junction, and you can see certain suture marks also which are present. And just have a look at the infiltrate. Infiltrate is white, it is crystalline, it has branches. Okay, so this is crystalline keratopathy. Now if you do an optical section or you put a slit using a slit lamp, you would notice that the crystalline deposits, these branching filaments, these are white, feathery, and they are present at all the levels of the stroma. It's not like they are present anteriorly or posteriorly. They are going to be present at all the levels of the stroma, and the surrounding cornea will not have any apparent cellular infiltrate or ocular inflammation. So that is an important point. Just have a look at this picture. So this picture demonstrates infectious crystalline keratopathy that you can see over here within the corneal graft. So it is looking white, crystalline branching opacity near the peripheral suture, and you can see that the associated inflammatory infiltrate is very less. You can compare it to that of the streptococcus pneumoniae, where we observed so much of infiltrate was present, so much hypopion was present. Over here we do not have any hypopion, we do not have surrounding inflammation. Similarly, have a look over here. This is crystalline keratopathy. Now, after going through the gram-positive organism, let us study about the gram-negative bacilli. The most common gram-negative organism which is causing corneal ulcer, and the most severe type of corneal ulcer, is Pseudomonas aeruginosa. Pseudomonas aeruginosa is actually a gram-negative bacilli. So what did I tell you about gram-negative? Gram-negative means they will be pinkish in color, and bacilli means they will be rectangular in shape. Okay, so they will be gram-negative bacilli. Now, Pseudomonas aeruginosa, it causes severe inflammatory signs along with a very characteristic discharge of the pus, and the pus is greenish yellow pus. Now, the progression of Pseudomonas is like fulminant acute progression. It progresses very rapidly, and it progresses in such a manner that it will cause melting of not just keratitis, not just that inflammation is so severe that you will have a corneal melting, and sometimes you will have a ring infiltrate, and that corneal melting of the stroma will be so much that the entire stroma might get melted and you might be left with only the descemet membrane, because the descemet membrane, as I told you in anatomy of cornea, is resistant to the enzymatic digestion, and therefore you will have a descemetocele. That means the entire stroma will be gone and you will have just the descemet membrane actually plugging the perforation, and that is called descemetocele formation. And later on, this descemetocele can get ruptured whenever there is a raised pressure within the eye because of coughing or because of straining in stools. So that will lead to perforation. So such a dangerous organism is Pseudomonas aeruginosa. The surrounding stroma will show ground glass appearance with diffuse graying of the epithelium. And the discharge will be very severe. It will be mucopurulent discharge, partly mucoid, partly purulent, and it will be greenish yellow in color. So have a look at here. The discharge is mucopurulent, and you can see this ring like ulceration. Actually here the cornea has become totally melted. This is called total corneal melt, seen in Pseudomonas. Similarly, here you can see severe inflammation, severe melting of the cornea, deep stromal ulceration, and here is the hypopyon also. Similarly, here there is a Pseudomonas. You can see here the ground glass opacity. Okay, so this is the ground glass opacification of the surrounding cornea with ring infiltrate. So sometimes you might get confused with acanthamoeba keratitis, because acanthamoeba also will present with ring infiltrate. Even fungal corneal ulcer will present with ring infiltrate, and Pseudomonas also can look like that. Similarly, here you just look at the cornea. You cannot make out where is the cornea. It is like extensive stromal necrosis with mucopurulent discharge in a patient with Pseudomonas keratitis. Now on gram stain, you will have this gram negative bacilli, and this is a culture of a patient. You know, Pseudomonas is very common isolate from the people who use contact lens and who actually use contaminated contact lens solutions to clean it. Sometimes patients using contaminated tap water to clean the contact lenses can also have Pseudomonas aeruginosa. Okay, Pseudomonas keratitis. So this is the contact lens of the patient, and the contact lens was taken and cultivated on the blood agar, and you can see the confluent growth of Pseudomonas aeruginosa from that contact lens. Another gram-negative organism which can cause keratitis, but mostly it causes very severe kind of hyperpurulent conjunctivitis with marked chemosis of the lids, and with stromal infiltration can also occur. And what is important here is the history. Patient will have gonococcal infection in the genitals also. So you have to ask history, and you have to ask about penile secretions also in these patients. Coming to the next organisms, which is nocardia. Now, nocardia is a new organism. It can cause corneal ulceration, but this corneal ulceration course is indolent. So in Pseudomonas, the course was very rapid. However, in nocardia, the course is a slow course and an indolent course. Nocardia can actually infect the eyes even after very minor traumas, particularly when the wound is exposed to contaminated soil. So it lives in soil and can easily contaminate the minor traumatic corneas also. What is important with nocardia is the importance of wreath-like configuration of the infiltrate. So it is characterized by these raised, superficial, pinhead-like infiltrates. They will be very small infiltrates, and they will be arranged in a wreath-like configuration or brush fire-like border with multifocal lesions. So just have a look at this. This is nocardia keratitis, which is showing these dot-like filaments. So one dot, second dot, third dot. All these dots are combined together and they are arranged in a wreath-like arrangement. Similarly, here you can see this, they look very rough kind of infiltrate with this pinhead raised infiltrates arranged in a wreath-like pattern. Very, very specific and characteristic of nocardia. Now, it is a gram-positive organism. Moreover, it is acid-fast organism. So, nocardia, you can see it is arranged gram-positive branching organism. Sometimes it can look as if we are looking at a fungus. However, these are not fungus. They are pseudohyphae from a corneal scraping with a patient who has nocardia. So, important thing is that they are acid-fast, and the specific type of staining that we do is called the Kinyon staining for nocardia. Now, the next organisms are the atypical mycobacteria. Now, we're not talking about the Mycobacterium tuberculosis or Mycobacterium leprae, which are the typical microbacteria. Okay, we are talking about the atypical mycobacterium, which can also cause keratitis. However, this keratitis is really, really slow progressive keratitis. And how do we get contaminated with this atypical mycobacteria? Usually there are two: Mycobacterium cheiloni and Mycobacterium fortunae. So these ones, they usually do not contaminate the cornea so easily. However, whenever the instruments are contaminated, like the knife or the blade, sutures, okay, sometimes after corneal surgery, even after LASIK, it has been seen that atypical Mycobacterium keratitis are very common. So they can cause lesions like solitary lesions, or they can cause multifocal infiltrates, and they will have a spoke-like margin. So what I mean to say is, if this is the infiltrate, they will have this spoke-like margins, and because of the spoke-like margin, it looks as if you have thrown a stone against a glass and there's a cracked windshield appearance. So have a look at here. This is the early mycobacterial infiltration. Just look at this dry, it's a very dry infiltrate. The surrounding cornea does not look very severe, and you can see certain spoke-like satellite lesions also. So similarly here you can see mycobacterial stromal infiltration with spoke-like extension. One spoke, second spoke, third spoke. So it looks as if it is a cracked windshield appearance. So there is no separation, so it's typically non-separative and characteristically assumes a cracked windshield appearance with multiple radiating lines. Similarly here you can see non-tuberculous mycobacterium with central stromal infiltrate. The associated corneal edema is very less. Okay, you do not see associated corneal edema. So indolent corneal ulcers will not have surrounding corneal edema. Okay, so it's an indicator that it is present since a long time, and you have to think in terms of atypical organisms like atypical mycobacterium. Now, they will grow on Lowenstein-Jensen media, which is a very common media used for mycobacterium. The other organism is Bacillus cereus. Now, Bacillus cereus is a gram-positive bacillus. Okay, so that means it will look violet in color. And the keratitis of Bacillus cereus usually follows trauma or wound contamination. And typically, they will form a stromal ring infiltrate, which is removed from the site with a very rapid progression to stromal abscess. So, similar to pseudomonas, very similar to pseudomonas. However, stromal melt might not occur, but it's nonetheless it is also very rapidly progressing lesion. Sometimes there will be a peripheral microcystic edema with a ring, and then later it will become a circumferential corneal abscess. So have a look here. This is a peripheral ring-like ulcer. Central part is clear, and this is one more gram-negative organism, which is aerobic organism. A very short bacillus is Moraxella. Moraxella, we have two species: Moraxella non-liquefaciens and Moraxella lacunata. Now, lacunata is usually associated with angular conjunctivitis. That means conjunctivitis just involving the angles. And typical appearance on the stain is the safety pin appearance. Okay, they look like the safety pins like this. Okay, and yeah, they will cause stromal. They can cause indolent course, or they can also cause deep stromal abscess. Okay, so it's an atypical organism which is not very commonly causing the corneal ulcer. So there are so many corneal ulcers. You can see so many organisms which can cause ring stromal ulcer. So let us just summarize the organism which can cause ring stromal ulcer. Number one is Pseudomonas. You saw the ring ulcer by Pseudomonas. Then Bacillus cereus. In bacteria we have these two. Then we have nocardia, which can form a wreath-like configuration that can also look like a ring. Then acanthamoeba and fungal corneal ulcer can also present with ring-like ulcer, which are a topic for discussion for another lecture. So this was about certain clinical features of certain common bacterial keratitis or bacterial ulcer. I hope it was useful. Thank you and have a nice day.